This is about choosing wisely. Those of you who are not from the States may not have heard about this program. The American Board of Internal Medicine in 2011 said, listen, let's start a project where each medical specialty will identify 5 tests or procedures that they really have a difficult time justifying. The evidence isn't there, so that we would then give permission to doctors to not do those tests. And so these groups came together, and they, the first group that decided to work on this was like 9 societies. The American Academy of Family Physicians, which is a big one. The American College of Physicians is a big one. And all of these 9 basically wound up involving 375,000 doctors in the first cut. And the idea here was to put these things out. And they were also done in association with organizations that could reach to out to the public. And so the partner in this project was the Consumers Reports kind of thing. And so, but there were about 14 others, like the small group called the AARP. AARP has 67 million members, and so to the extent they are supporting this, that's good. And then they have the Leapfrog group, and there's all of the others that are listed there. So it's a kind of like a layman physician coalition to address tests and procedures that really ought not be done, or if done, should really be considered to be discussed with the patient in terms of this shared decision-making idea. And so that was kind of the general idea. Clearly, the idea of sometimes the tests we do are, they're no big deal, but if the test is positive, then you may begin a cascade of events where the next test, which is going to more clarify the situation, is riskier kind of thing. It might be a biopsy, or it might be some other test that involves radiation or those kinds of risks. There was a woman who was a contemporary of mine who never get a routine chest x-ray. It's a big frickin' mistake. Anyway, she got a chest x-ray out of one of these kind of health maintenance kind of things, and they saw a little ditzel on there, and they said, maybe we ought to biopsy that thing kind of thing. And so she went in for this open biopsy in her lung, and they had basically some kind of series of complications, and she died. She was a young doctor, she had kids, and she was probably in her 40s, and she died from the pursuit of the ditzel that turned out to be nothing. And she was based here in Los Angeles, and a lot of us knew her. So in any case, this project has been initiated, and the consumer groups have, to help the patients be aware of this project, have come out with a bunch of these booklets. There are 17 booklets, and there's going to be a lot more. And they're pretty straightforward. Bone density, when do you need one? Colonoscopy, when do you need one? Imaging tests for lower back pain, when do you need one? So it's kind of like to get the patients in sync with the doctors, because the patient's belief is the more the better. The more tests I have, the better. And this is trying to say, treating sinusitis, don't rush to antibiotics. So there's this whole litany of them based on the initial recommendations that were made by the first groups. The American College of Emergency Physicians initially opposed being involved in this project, which was very embarrassing, but they ultimately got it right, and around December or so said, yeah, we'll participate. We had embarrassed them a little bit about that, but they ultimately decided to do the right thing. They said, if we come up with a list of things that doctors shouldn't do, then it's going to increase their liability. We might not get paid for those things if we do them. But there clearly are egregious things that we know that we do. In fact, there's a great series of papers on women who have pap smears in primary care who have had their uteruses removed. Have you heard of those papers? They have no uterus. These women are still getting pap smears by doctors who think that that's something to do. And it's truly embarrassing. And it's not like one or two rare kind of thing. The percentage of women who are having pap smears under those terms are surprisingly high. And there are things like it doesn't really matter. So you ordered an amylase instead of the lipase. Is not ordering amylases, does anybody care? That could be one of the things we say not to do. So there's hardly any consequence in that. And there's no consequence in, even though amylase you don't need anymore now, we got the lipase. And there's this idea of giving IV fluids to asthmatics. Literature says giving IV fluids to asthmatics is a total waste of time. Their mouths are working. They're not dehydrated. This idea of we're going to make the secretions thinner by drinking a glass of water is 1960s. And the same thing about, let's give them IV fluids for that kidney stone. It's like we're going to, we're washing down the driveway with the hose, and that's going to push the stone out kind of thing. It doesn't work that way. The kidney is blocked. The good water goes out the good kidney. You're doing calisthenics on the good kidney while you block up the bad one. But nobody cares. That's not a big deal. So it's going to cost a couple $100 for that $1 bag of IV fluid. It's not going to hurt them. But there are things, basically, that may, in fact, hurt people that we do pretty casually and without evidence. And so I'd just like to use this like one example. It's the performance of CT pulmonary angiograms for the topic that was just being discussed here, the idea of, do you have a PE? Well, let's do this test. What we should agree on is the strategy is every person who you think has a possible PE, you're supposed to basically risk stratify them. That must be the first step. Low, intermediate, or high risk. If they have high risk, they get the scan. If they have intermediate risk, if you're in Europe, you do a D-dimer, and if D-dimer is negative, you go home. If you're in the United States, if you're an intermediate risk, they'll send you for a scan. And low risk, whether it's by your own gestalt or you're using the Wells criteria, the Geneva criteria, whatever, low risk patient, they're supposed to get a D-dimer. If that D-dimer is negative, the workup is over. That is, I think, pretty clear in the literature. Well, that being the case, let's look at what some of us are doing if that's the situation. Because obviously, doing pulmonary angiograms, there's a lot of radiation involved with it, and there's contrast involved with it, and there's the risk of contrast-induced nephropathy. There was a paper we just did that showed 14% of people who got CT pulmonary angiograms had a bump in their creatinine. Whether that's bad or not, it occurred. So let's look. And so there's 3 papers there to just kind of go through this. The first paper is by Dr. Corwin and associates. And in that study, 7% of low-risk patients with a negative D-dimer, who are not supposed to have anything further, got CTPA, 7%. He said, well, that wasn't that horrible, but what would justify it given what we know? The next paper, Theismann, 14% of low-risk patients received CTs who had a negative D-dimer. Do that again. 14% of people who had low risk and negative D-dimer got a CT. I mean, who's justifying that? Who's doing? And catch this: imaging for venous thromboembolism was not performed in 47% of the patients with a positive D-dimer. So they were low risk, positive D-dimer, and in half those cases they said, I don't think we really need to do that next test. Let's just stop here. And it's like, how can you defend that? You really can't. Yeah, there might be 1 or 2, but not 47%. And then the third paper by way of background said in its introduction that between 7 and 25% of imaging studies for PE can be avoided. That's a lot. So their study, this is by Dr. Venkatesh. In their study, a third of patients with a low clinical probability of pulmonary embolism and a negative D-dimer, or a D-dimer wasn't even performed, got a CT pulmonary angiogram. I mean, it's like shocking. Negative D-dimer, or we didn't even bother doing it. Let's just send them. They're low probability. I know, fine, but let's just send them. This is called the art of medicine. which basically means that evidence-based medicine just left the building. So there's 3 examples of something that we do with some surprising frequency. So let's look at some of the things that these other medical societies have said that relate to primary care and emergency medicine. We don't have to take a lot of time on them. Don't order sinus CTs or indiscriminately prescribe antibiotics for uncomplicated rhinosinusitis. So says the American Academy of Allergy, Asthma, and Immunology. And they list the reasons why you shouldn't, and I think most people would acknowledge that. Sinus series CT, just treat it if you think they have it. It's one of the interesting things about sinuses is that we say sinuses need to be treated with antibiotics for a real long time, like 2 or 3 weeks. Is there another explanation about why we think we need to treat sinuses for 2 or 3 weeks? Maybe treating sinuses for 2 or 3 weeks means that antibiotics don't work. We don't treat anything else for 2 or 3 weeks. We treat bladder infections for 3 days. We treat a cellulitis for a week. We treat a strep throat to try to prevent rheumatic fever for 10 days, but nobody's going to take it anyway. So the studies have shown if you want to get rid of a sore throat, strep throat, a week is more than generous. And yet we're going to treat sinusitis for 2 or 3 weeks because they're just tough infections. They're really pretty resistant. Or maybe they don't respond to antibiotics. That would be another way to look at that. But in any case, that was one of them. And one of the things in this series is they don't say, if one organization says don't order back x-rays, and the other organization says don't order back x-rays, they don't say, hey, no, that was already been taken. So there is some duplications here. Don't routinely prescribe antibiotics for, the second one. And who's that from? That's from the American Academy of Family Physicians, of which there's a bajillion. They say there are 16 million visits for sinusitis, almost $6 billion a year spent. Antibiotics are prescribed by doctors in 80% of cases because what else are you going to do? They've been waiting out there for an hour. You're going to tell them, well, it's probably viral and it's likely to go away. My granddaughter is 2 years old, and she goes to daycare, and she's been coughing for about a week. And every day that she goes to daycare, the daycare people say, haven't you seen a doctor yet? They make the parents feel like jerks because this child continues to cough for a week. Of course, she's terrorizing the entire place. She's eating everything. She had a little fever now and then kind of thing, but these are obviously negligent parents. And so I checked her out on Skype, and she was 100% perfectly fine. And I couldn't even hear her cough. But the parents say, well, the school won't let her in. And I said, well, just tell them she saw a doctor. Come on, She did. She saw a doctor, damn it. And but that's the kind of pressure. So you can envision what would happen. So the kids now got to cough for 7 or 8 days. They've been intimidated to go to the doctor because of the cough. They wait for the doctor appointment kind of thing. What's the temptation on the part of the doctor to say, well, let's give some ampicillin or other. Let's give it a try. It's probably a virus. And then the diarrhea, then the diaper rash, it's such a trap that we fall into. But in any case, that's what they said. Don't diagnose or manage asthma without spirometry. That's according to the American Academy of Allergy, Asthma, and Immunology. I don't know. I can't get too excited about that one, honestly. Anyway. Don't do imaging for low back pain within the first 6 weeks unless the red flags are present. That's the American Academy of Family Physicians. That's also said by the American College of Physicians. Low back pain is the 5th most common reason for people seeing a doctor. And so it turns out, when you talk about the back pain, all you need to know is the 7 or 8 red flags. Nothing else matters, because if you know the 7 or 8 red flags, you'll pick up all the serious ones. And that leaves all the mechanical ones that are left from I hurt myself lifting a box at work kind of thing. And x-rays are not going to tell you what to do. They're not going to show you the pathology. Time will make it get better. Don't mess with it. You know, you can entertain them by sending them to PT for a while, if that's what all the other people who got an industrial back injury got, called shake and bake, which means just basically keeping them out of the way for a while. But the idea is, you know, back pain is such a huge problem in this country, and when the government tried to come out with guidelines to help people deal with this, the American Academy of Orthopedics had a stroke because of the limitation of the recommendation about the limitation of X-rays and the idea that this is going to resolve it by itself, which it generally does. And they really put the brakes on the ability of the government to generate clinical guidelines. Now that organization basically takes other people's guidelines and pools them together and says, here's where they are. In the evaluation of simple syncope and a neuro exam, don't obtain brain imaging studies, CTs or MRIs. I was looking last night for the paper that we did on syncope and I think it's in the pipeline because I didn't find it in any of the abstracts. But I do know that we did a paper recently on imaging of syncope patients that have neurologic exams. The numbers are surprisingly high of people who feel that if you passed out, we have to do something and look inside your brain. The literature just really doesn't support that. Then there's the ones that talk about the next one, this low test pretest probability and scanning for pulmonary embolism. We already went through that. There's two of those. American College of Physicians and American College of Radiology also came up with recommendations in that are similar. Don't image uncomplicated headaches, so says the American College of Radiology. This is one of the ones that annoyed ACEP, because the radiologists, they don't order X-rays. They accept orders from other people. So here they're saying to us, don't order that CT for a headache, for crying out loud. And CMS basically had a long list of criteria of people who ought not have it. There was a paper that we did, it looked at the staff, the faculty at Brigham and Women's Hospital, big time hospital, teaching all the residents what the right thing to do is. And they look at that, the ordering of CTs for headache patients by their faculty. And one faculty member CT'd 20% of every one of the headache patients that person saw, 20%. That was the low doctor. One faculty member CT'd 60% of every headache patient they saw over a year's period of time. And so what does that teach the residents? It teaches the residents that you better light these people up, because that's what we do in academic medicine, and we're at Brigham and Women's Hospital, a very prestigious place. This is the way you do good medicine. And it sends a terrible message, because the faculty are so risk averse there. They're so chicken, they're so afraid that they're teaching this medical putty, otherwise known as a resident, to order everything. And yet, there really clearly got reasonable guidelines for when you ought to get a head CT. Avoid admission or pre-op chest X-rays for ambulatory patients with unremarkable histories in physical exams. So says the American College of Radiology. But we aid and abetted that. Only 2% of such images lead to any changes in management, they found in a study that was done. And sometimes when you hear about, a change in management, well, that's why we should have done it. That doesn't mean the change in management was reasonable or necessary or appropriate. But we aid and abet. This person's going to get admitted for appendicitis. Well, we better get that chest X-ray, get that urine. I remember a girl that had a supracondylar fracture of their elbow, and she was probably 4 or 5 or 6 years old, kind of thing, and she was going to go to the operating room and have that thing pinned because it was unstable. And the anesthesiologist basically said, has she had her UA yet? And I said, UA? No, the doctor, it's the elbow problem, elbow. We're going to go through the elbow. You put a little pin in the elbow here. No, she's going to we're going to put her to sleep, and so we need the UA. And I said, come on, doc, she says she's not coming to the operating room without a UA. And this is kind of like rampant throughout the rest of the country, this necessity to have a handful of lab slips to get into the operating room. Mayo Clinic has had for decades a system of here's what the preoperative test would be based on your age, this is really silly. They ask you your history about what you've had in the past to determine what preoperative test that you need. And yet, we knee-jerk, everybody gets it. Don't obtain pre-op, I read that one. Don't do CT for the evaluation of suspected appendicitis in children until after ultrasound has been considered as an option. You know who said that? The American College of Radiology. And yet, if you ask any radiologist at your hospital in the United States of America, we'd like to do an ultrasound first, they're going to say what? What's that? It's the American College of Radiology said that. The literature on it's super compelling. Put that little jelly on the belly, no radiation. The sensitivity of ultrasound in places where they do it a lot is 90%. The sensitivity CAT scan is 95%. We're talking about a 5% difference. And it doesn't mean that if you have an equivocal ultrasound that you can't get the CAT scan then. As a matter of fact, Stanford has published 2 studies where they did this 2-step fashion. They did ultrasound, and if the ultrasound was couldn't see the appendix or was equivocal or something like that, they would do a CAT scan. And they reduced the number of CAT scans in these little kitties there by 50%. And I spoke to and I interviewed the chairman of radiology at Stanford, and I said, how come it hasn't gotten any better than that over time? And he threw the emergency physicians underneath the bus. He said, those are the ones who are ordering it. It was hard to believe, but that's what he said. So the idea of doing ultrasound, our doctors in this country, they don't feel comfortable doing that. They said, I think a 2-week course in Cancun would fix this. I really do. You look at the Israeli studies, you look at the Dutch studies, these people got it down. You can't tell us our radiologists can't do this. And there is a consequence. We're irradiating 7-year-old kids who have appendicitis, who don't need to be irradiated. And I don't know, has any of your hospitals kind of moved to the ultrasound first position on this? Is your hospital in the United States of America? Canada, no. No, of course not. Is there any American hospitals? Where are you, doctor?
We're in Schenectady, New York. We do ultrasounds on all the kids prior to CAT scan.
Are you at a children's hospital? No. No?
Michigan, Dearborn, Michigan. We do it and we have a PEDS unit, but we're not a children's hospital. That's the first one.
And
Bar Harbor, Maine, and we're a community hospital, and we've had that policy for a couple of years.
Community hospital in Pennsylvania is small, and it took us 9 months to get our first positive appendicitis.
well, that's just it. We got to keep on checking that box. Just keep on checking that box.
And it's changing. We're starting to.
So there's 6 or 7 hands here that have gone up. I exclude always the foreigners because they're generally doing it. Are you guys doing it? Ultrasound first in New Zealand and Australia? I thought there were laws against child abuse. That's what our colleague said here. So it's like, man.
Yeah, I've actually had our radiologists say they let the CT not be less accurate in kids because they don't have as much fat.
Oh, actually, if you want to read a little something about CTs and appendicitis, and although it's focused on the use of oral contrast, I think the next issue of Emergency Physician Monthly, with is everybody in the United States gets. There's an article I wrote in there that I think honestly is very, very compelling. That should be used to facilitate you being if you're going to do CTs, that you don't need contrast, IV nor oral in these cases. It's the official policy of the University of Southern California here: no oral contrast ever, including unless you expect there's a hole in the bowel. This is for the residents and the faculty, and that I've got that in there to give you as much support as possible. But this is powerful. This is the radiologist saying, do ultrasound first. Take it to them. Take it to your guys and see what do they say. The literature, I mean, if you were to gather it, it's very straightforward. They have to get good at it, though. They need to practice at it. And then they say basically avoid non-steroidals in individuals with hypertension or heart failure or kidney disease. We give out non-steroidals pretty liberally in a lot of situations where the process is not prostaglandin mediated or an inflammatory process, although it's really kind of interesting. We did a paper in the abstracts this past month on the use of IV acetaminophen for the treatment of kidney stones. And I said, why would anybody make IV acetaminophen? This drug has got to be total junk. It equaled morphine in good doses. 1 gram of IV acetaminophen equaled morphine in a nice study that it had really no basic flaws in it. And then at the end, in the discussion period, they listed 3 other studies where they basically showed that IV acetaminophen was as good as morphine. And 1 gram. Oh, no, 0.7. It was 0.1 per kilogram. So that 0.1 per kilogram is a reasonable starting dose. That's 7, 8, 6. And Dr. Hoffman's theory was that if you put 1 gram in and avoid the liver in terms of first-pass metabolism and have it right into the bloodstream, that you're getting astronomically high levels, and that really high levels of acetaminophen can be very effective analgesics. But when you take it by mouth and it goes to the liver and it gets metabolized, that you don't get the same blood levels. That was the theory, but we couldn't find anything wrong with the paper. There's got to be something wrong with it that we couldn't find. And then there's 3 others that said the same thing. So sometimes when we see things that don't seem to make sense, I thought this was just a pure marketing ploy. I don't think so, I guess. Well, IV acetaminophen has been in Europe for 20 years. It's been here for like 2. Jerry?
Can we get IV here?
Yeah, it is. It's been here about 2 years. And I have no idea what it costs. They probably grind up a few pills in there and it can't be cheap. But, it doesn't put people to sleep like morphine does, and nobody was vomiting like morphine does. You can give it with ketorolac, it doesn't, there's no reason not to do that. And it was really fascinating. Well, it seems it's not unique to kidney stones. It's not got any prostaglandin synthetase activity. It's acting as a pure analgesic. So I think that this is going to open the doors to all kinds of studies of the use of IV acetaminophen for painful things.